Hello, everyone. Welcome. My name is Christia Moby, and I work in the product division with Xstrahl, and I will be the moderator for this event. We are delighted to welcome Dr. Olivier Keravel from Eiffelvet, who will discuss the use of radiation therapy for small animal medicine and the role of orthovoltage radiotherapy as an important and cost-effective treatment modality. Dr. Keravel received his veterinary diploma from the Veterinary School of Masons-Alfort. He completed additional studies with the Gustave Roussy Institute and Ohio State University before starting his veterinary clinic. He created the first private veterinary imaging center in France and went on to author and publish the first veterinary book devoted to small animal CT scanning in 2011. Dr. Keravel created Eiffelvet in 2014 as the first referral veterinary clinic dedicated to oncology only. Dr. Keravel will describe the reasons he chose orthovoltage radiotherapy and the different protocols used in terms of dose and scheduling. He will also present several cases. Thanks again, and with that, I will hand it over to Dr. Keravel.
Okay, hello everybody. Thanks for Xstrahl to invite me for this webinar. I'm going to try to talk to you about orthovoltage today in our clinic at Eiffelvet and try to make you feel how convenient is this facility. So first of all, the introduction. It's going to be a general introduction just to make you feel that you need to include radiation therapy within a strategy. It's a general strategy that you need to put up with your onco patients. So vet oncology is about quality of life. That's really important. Keep this in mind. The therapeutic observance is often very difficult. So you need to avoid, in fact, side effects in vet oncology much more than in human oncology. If possible, you need to be multimodal. That means your radiation therapy is not going to be the only modality that you're going to use to treat the cancer. And everything is working through a synergistic optimization system. And we know now that sometimes when you do radiation therapy, you're doing a little bit of immunotherapy. Sometimes you're going to use chemotherapy because it's going to be a radiosensitizer, etc. Last thing is timing, scheduling, chronology, because you have to think in advance your radiation therapy protocol as everything in your oncology treatment. If you want to do, if surgery has been done and you get your patient, you need to wait a little while before you do your CT, for instance. Otherwise, if you do the CT too early after surgery, you will not be able to differentiate an inflammation on CT versus a residual disease, etc. And it's the same for radiation therapy. If you want to do radiation therapy in an efficient way, you need to planify it in advance before the surgery, because you need to do it between 3 and 5 weeks after surgery. So when you have a clinical suspicion of cancer, the first thing to do is to remove the knives, anything. Don't go for surgery. Please be patient. Do a checkup. You're going to do blood work. You're going to do cardiac ultrasound. You're going to do urine analysis. You're going to make sure that your patient is able to undergo a multimodal anti-cancer treatment. You know, don't send me a case of a cat with cardiomyopathy for a hyperfractionated protocol, because I will have to do 12, 15 anesthesia, and it's going to be dangerous for the cat. Same thing if the dog or the cat has renal insufficiency. There are some chemo we will not be able to do. And last thing, when you're facing a cancer, use first-line NSAID. Avoid steroids if possible. And there are two molecules, firocoxib and meloxicam. These two molecules are the only NSAID for which we have sufficient data in the literature to be approximately sure that we will have an anti-angiogenic effect on the cancer, generally speaking. So when you have a clinical suspicion of cancer, you've done your checkup on your patient, and you want to go forward. Usually you're going to do a CT. And the CT is an easy way to look at the same time at the tumor, at the lymph node, and at the same time You're going to look at the lungs, look at the bones, look at the abdomen, etc. So it's a very easy facility, and we're using on an everyday basis in oncology. And don't forget, you cannot do radiation therapy to planify your radiation technique without a CT. During the CT, you're going to look at the primary tumors. You're going to look at the metastasis in the local regional lymph node. You're going to look at the primary tumors, see if it's vascularized, if it's necrotic, if it's surgical, etc. And then you're going to look at the lungs and at all the organs of the abdomen to make sure you don't have dissemination far away from the tumor. And at the same time, you can do cytology, you can do biopsy. On the biopsy, you will, if it's a mast cell, you're going to ask for a Ki67, etc. So everything starts from the CT, cytology, and biopsy that you will do during the CT. So watch your steps. Please do the checkup of your patient before sending the patient to us. Assessment of cancer extension. We talked about this with the CT. And then only you will go for your onco consult. And during the onco consult, you will talk with the client. You will examine. You will do a physical on your patient. You will have all the information of the checkup of your patients. You will have talked before with your referral vet, and then you're going to end up with an individualized therapeutic strategy. It doesn't mean that you will be able to go all the way through the strategy, but at least your owner will be able to understand every choice, and all the choice for the strategy will be made with the owner. Okay, still in introduction, some general ideas about radiation therapy. It's a local treatment. Never forget about this. You cannot do radiation therapy if you don't have a CT. Radiation therapy, if you want it to be curative, if you want to put yourself into an ideal situation to use it, you need a small volume tumor, you need a radiosensitive tumor, and you need a tumor with local aggressivity and no met, in the lymph nodes or anywhere else. So useless to say it's not the classic situation that you're going to encounter with our dogs and cats patients. Few rule of thumbs. Sarcomas are usually radio resistant. We all use radiation therapy post-surgically with soft tissue sarcoma, fibrosarcoma in cats. But on a macroscopic settings, sarcomas are usually resistant. On the other hand, mast cell tumors, melanomas, carcinomas are very radiosensitive. And look at your histopath record. That's really important because the more mitosis you have, the better. Like chemo, you want a tumor growing actively to be more efficient with chemo and radiation therapy. As a conclusion, you understand that most of the time you're not going to be curative using radiation therapy, but that's okay. It's going to be included within a multimodal protocol. You can use it for just a palliative settings, analgesics for osteosarcomas. You can try a palliative pure anti-neoplastic effect in nasal cavity, oral cavity, mediastinum. That is fine too. So now, introduction to orthovoltage. The question you may ask me is, why did I choose orthovoltage versus linac? Orthovoltage use photons, fairly low energy photons. Linac, you can use photons, you can use electrons. So you have, of course, an advantage with the linac for the deep parenchymal tissue, for the axial brain tumor. Don't ask me to irradiate with an orthovoltage a glioma in a 50 kilo dogs, of the brain. It's going to be difficult. On the other hand, we chose orthovoltage because on superficial tumor, it has a very good advantage because most of the soft tissue tumors we will encounter are not that deep. They are considered superficial on a human point of view. And you have, in fact, an advantage because most of the time you need to irradiate the skin. You need to irradiate the subcu. And in most of the subcutaneous canine, feline, or cutaneous soft tissue tumors, you have an advantage using orthovoltage. So pros for orthovoltage: superficial skin involvement, that's important. Um, Second point, very important, it's cost effective for the vet and the owner. What I mean is that shielding of an orthovoltage machine is much cheaper than shielding for a linac. You will be able to provide radiation therapy to your patient for a cost much lower than linac. And you will not have the bank behind your back telling you you need to do such and such number of radiation treatment per month because you need to pay me back for the machine. So that will bring you into a situation where you will only have to think as a vet as the interest of your patient and never think of the bank, because you will be able to make money fairly efficiently with the orthovoltage right away. So that's, I think, is very important on an ethic point of view, and important for the owner. Ease of use, that's true. It's very easy compared to linac to position your patient, and you can do intra-op radiation therapy. We'll talk about this, much easier with an orthovoltage than with a linac. It's also easy to position your patient itself, quicker to position your patient itself with orthovoltage. So anesthesia is usually shorter. So there are a lot of pros for orthovoltage. We're using 300 kV. Remember that in most of the articles from back in the 80s in veterinary medicine, they were not necessarily 300 kilovolt orthovoltage. Of course, there are some cons with orthovoltage. We talked about low energy photons. We talked about limited indications, difficult to irradiate an axial brain tumor in a big dog, difficult to irradiate a nasal cavity tumor in a big dog. Something that is usually opposed to you if you want to do orthovoltage by the radiation therapy people in veterinary medicine is that you cannot do dosimetry. Well, that is true. You cannot really do dosimetry, but you can have a physician work on your orthovoltage. I will explain you later. You will know which dose you are delivering at such a depth of the patient. So you're still controlling the dose you're giving your patient. You need to understand what you're doing, and providing you're providing relief to your patient. Well, you don't have dosimetry, but it works. So that is fine in my opinion. Operator dependent. So that's a critic that can be done with orthovoltage. That is true, because you need to understand your machine, but as any machine, you have some, even with radiation therapy with linac, one radiation therapy people will not do the same protocols as another one. So, okay, it's operator dependent, but what is not operator dependent? Most of the technique we're using are operator dependent from one way or another. Low precision on a millimeter basis. You have to know that orthovoltage was used in humans before linac appears, basically. But when you talk, and I had the occasion to talk with all radiation therapy people that are now retired that have used orthovoltage a lot, and they were telling me, okay, well, we have the linac now, but with orthovoltage for the margins, I was happy. And as a matter of fact, if you're too precise around a tumor, and while you're not necessarily going to treat with a sufficient dose the margins, and you may have recurrence on the margins. So being not very precise on a millimeter basis, in a way, is an advantage in oncology, in veterinary oncology. So you have your filters, you have your applicators, and you have the physician in your building. When you buy your orthovoltage, it comes here, and for each filter, for each applicator, you're going to have a diagram, okay? And this is the depth, and this is the decrease of the dose from the skin, 100% of the dose at the skin. And for instance, if I want to deliver an 8 gray dose at 3.5 centimeter, I will know that I will have 3.2 gray if I have 8 gray at the skin. And every year your physician is coming back to reevaluate your machine and make sure these diagrams are still good. And for instance, here on this image, you see the medulla right there, where you know you're 3.5 centimeters approximately from there, and you have some, you look at the books, and you know the maximum tolerated dose on the medulla is going to be 45 gray. Well, so you know that you're going to deliver 3.2 gray close from the medulla, so you're fine. You're far away from the maximum dose. That's approximately how you calculate the dose you're going to deliver where you want to deliver it in our patients. And here, this is a Jack Russell with mast cell tumors. That's a Husky with proximal humerus osteosarcoma. That's a cat with a third eyelid lymphoma. And here underneath the surgery sheet is a cat. And we're doing intra-op radiation therapy to this cat. So when you do radiation therapy, you're exposing yourself to side effects. Whatever, orthovoltage, linac, you always has side effect. The immediate side effects are for quick proliferative tissue, skin, mucosa, epithelium of the intestinal, cornea, and it burns. Usually it burns more in dog than in cat. With orthovoltage, we're fairly fine. And you can deal with this immediate side effect. That's okay. And sometimes you may delay a little bit your protocol to wait for the skin to heal a little bit. If you have to do it, you do it, The late side effects are more for the slow proliferative tissue, so it comes later on. It's going to be the hair. It can grow it cannot be able to grow again, or it's going to grow for a different color. Be careful to the lungs, be careful to the lens, and the bone. So that's important because when you want to do orthovoltage, sometimes the radiation therapy people in veterinary medicine will tell you, well, be careful because you're going to have a lot of bone necrosis. Well, that comes back from the articles in the 80s. To be honest with you, we've been using orthovoltage for over 7 years, and it's not really a concern for us. We are careful. We always are honest with our client. We may had 3 or 4 cases of squamous cell carcinoma of the jaw in cats where we had doubt that we could have had bone necrosis, but it could have been necrosis from the tumor itself. So I did not have cases, to be honest with you, where I was sure 100% that I caused bone necrosis in my patient, and even in nasal cavity tumors. Well, the main reason is that if you're using orthovoltage on a palliative settings, well, you know that your patient is not going to live long enough to encounter these late side effects. So we end up with 3 main protocols at Eiffelvet. Curative intent protocols. Well, you're going to do surgery on a soft tissue sarcoma. You have dirty margins. The rest of the CT is normal. You want to clean your tumor bed, and you're going to do hyperfractionated radiation therapy, hoping it's going to be enough to control the tumors. You can use it if you have high-grade tumors with clean margins, and you're not sure even with clean margins that will be enough. Basically, we're using it post-surgically in local aggressive tumors, like certain soft tissue tumors, and we're using it on very small, superficial, locally aggressive tumors. Then you have the protocol that we're using a lot. It's more a palliative protocol. It could be used as an analgesic protocol in osteosarcoma in dogs. If you have a cat with soft tissue sarcoma and you know he has cardiomyopathy, you're not going to be able to do a hyperfractionated protocol. So you know in advance from the surgery that it will go for a palliative protocol, meaning that you are going to lower the number of anesthesia. And usually we do 3 to 4 radiotherapy sessions, G1, G7, G21, G28. And sometimes, and most of the time, we're going to add a chemo, radiosensitizing chemo and carboplat that we're going to do at G1 and G21 because you need to do every 3 weeks your carboplat. And the third protocol is going to be intra-op, where you're going to irradiate the tumor bed, and I will explain it to you later. So the third part of the speech is going to be about the curative intent protocol, and I'm going to give you example of this protocol. So that's the third eyelid lymphoma picture you had later on. That's before radiation therapy. That's after radiation therapy. This cat was belonging to a vet. So as you know, if the cat is belonging to the vet, it's going to be a difficult case. So we did hyperfractionated radiation therapy on the first eyelid, and another lymphoma appears in the other eyelid, and we did another hyperfractionated protocol. Every time in this cat, since it's a lymphoma, you want to make sure it's a stage 1 lymphoma, and that you will be efficient to have a long survival with just radiation therapy. So you do a CT of the skull, you do a CT of the thorax, of the abdomen, you look for any lymph node. You're going to punction your lymph node, the submandibular lymph nodes. You're going to punction your spleen, you're going to punction your liver. You want to make sure 100% that is stage 1. It was the case for this cat. And as you can see, over 3 years later, the cat was fine. You had a little ulceration on the internal canthus, little bilateral corneal opacification, but the cat was fine. And unfortunately died of cardiomyopathy in 2019. That's the case of nasal lymphoma. Same thing, you want to make sure it's a stage 1. So you do your workup with the CT, with your lymph node aspirate, and you wear in the body, and you go for the radiation therapy, and it works fine. It gives comfort right away to the cat. The problem with this cat is, unfortunately, he died of renal insufficiency pretty quickly after the treatment. He was cured of his cancer. So, the 7 months he survived is usually the time, the average disease-free survival time you can have with high-grade lymphoma in cat. But this cat has renal insufficiency. He could have lived much longer like the cat before. But just to remember with this slide that be cautious with the renal function, be cautious with the cardiac function in cat. That is really important. Truffle squamous cell carcinoma, of course, it's better if it's superficial. This one was pretty deep, down the truffle right there on the sagittal view, and here on the coronal view, you can see right there, the tumor is pretty thick. It's not 100% the truffle, and this is where the tumor was, and this is the tumor after radiation. And basically, this dog was cured of its cancer with our hyperfractionated protocol. That's a Bernese Mountain Dog. That's inter with a big mast cell. It was a high-grade mast cell, well, a grade 2 with a high Ki67. We had a dad on CT with a few lungs lesions, mets or osseous metaplasia. We're not sure. So we treated the case with a hyperfractionated protocol, and we add limblastin, 8-dose classic chemo protocol for high-grade mast cell tumors on top of it, because we couldn't go for surgery, and there was a doubt in the lungs, and it was a high grade. And basically, this dog inter was cured of his cancer. We've done a couple of CT later on, and this lung lesion never moved, and we've seen this case approximately a year ago for inflammatory bowel disease, but the inter is cured of his big mast cell. So now the palliative and analgesic intent protocol. So number of situations where you're going to use it. And I try with another case of dog's truffle squamous cell carcinoma. This dog was belonging to AMDs. So like vets, it's going to be a problem. So we do the diagnosis. There are some really suspicious hepatic lesion, but too close from the diaphragm to be able to stick a needle in there. So we have to do without. The owner didn't want to do a hyperfractionated protocol, so we went for the hypofractionated protocol with just 3 sessions, G0, G7, and G21, and we add 2 carboplat chemosensitizing on G0, G1, and G21. We had a local recurrence, and that's a tumor. You can see, like the other one, is pretty big and infiltrative tumor. It's not really a superficial one. And we had a local recurrence on the periphery of the zone we irradiated. So we gave 2 additional radiotherapy sessions on this zone, and we started immunotherapy on this dog. We used thyrocoxib, metronomic chemo, and a tyrosine kinase inhibitor, and in this case, Palliative. That's a palliative immunotherapy protocol we're using a lot at Eiffelvet on top of chemo and radiation therapy. We unfortunately had to stop Palliative because we were looking at the kidney function. It was not working well, so we stopped it. We check on normal abdominal ultrasound. We did continue Previcox, thyrocoxib, and cyclophosphamide on metronomic chemo. We had to stop. We tried Massivet, another tyrosine kinase inhibitor, but still we had side effects. We had to stop. And we did a normal CT in June 2020. That was over a year after radiation. Unfortunately, there was a recurrence in this dog, and we're still controlling the tumor, but we've done electrochemotherapy on a second intent protocol. But the dog is still doing fine. So it's not always easy, you know, the dog's trophocyst carcinoma, but usually you can manage to control them. Sherry is a very good case, and that's a very good example to give you and to make you feel how powerful is orthovoltage and give comfort to your patients with a very little risk. Cheryl, she has chronic renal insufficiency when we diagnose her with mediastinal lymphoma. So impossible to do chemo. You're going to kill this old cat. You know, she's already old. You know, she's 13 years old when we have her first in consult. So we decided to go just for palliative radiation therapy. We just control with X-ray, not CT, because we didn't want to do any additional anesthesia. And it's not perfect, but the cat is fine. She stayed fine for a number of months, and we did a consolidation with a fourth session of radiation therapy, every time A gray. She has a recurrence in April 2017 and another dose, and it gave her 3 months. And you can see this cat. She has renal insufficiency. She has mediastinal lymphoma, bad prognosis, just with 5 anesthesia. She lived nearly 2 years. So that's good. That's another case of mediastinal lymphoma in a bobtail where the owners denied any difficult treatment. But the mediastinal lymphoma in this dog was creating a lot of discomfort. So we decided to propose them just 3 sessions of hypofractionated protocol, just 1 dose of vincristine. And the owner refused to give any more chemo. And the dog, lived, you see, 8 months with just 3 anesthesia and 1 chemo. And you can see here on the CT down there how efficient is the radiation therapy with orthovoltage, even in a big dog, to give comfort. Urothelial bladder carcinoma. These are really good tumors, and we treat them with a multimodal protocol. We give chemo on top of orthovoltage, ultrasound-guided orthovoltage, hypofractionated protocol. That means every time, you know, we use the ultrasound to see and to modify how we're going to irradiate the bladder. And in this case, the owners were MDs that they didn't want to do much, so we couldn't do any chemo. We could just they just accepted hypofractionated radiation therapy, ultrasound guided, with thyrocoxib, and basically the dog, it's a Westie, where she's still alive. She's still alive. She's still doing fine, and you can see from this image on the ultrasound or this image on CT how much we managed to make the tumor disappear. So you can have long survival with ultrasound guided orthovoltage plus chemotherapy followed by immunotherapy. There's one thing about these urothelial cell carcinoma in the bladder of these dogs is that's the only tumor I will not stick a little. I can stick my needle anywhere in our patients. But with these tumors, you have a high risk of seeding when you do this. So we know that there are some of these tumors that are low grade, some of them are much more aggressive, and you cannot always differentiate them from imaging, because when you look at the size and on ultrasound, you know, it's a fairly big tumors and it looks aggressive, but in fact, it's probably not such a very aggressive one. Anyhow, these multimodal protocols on urothelial cell carcinoma are very efficient with orthovoltage, and we will try to present a series at VCS in October if we can. That's another case, Tadeo. That's a sublingual carcinoma. That's an old cat. He's nearly 19 years old when we see the cat. He has sublingual squamous cell carcinoma. He has renal insufficiency. So we only, pretty much like Cheryl, we did 3 sessions of radiation therapy, and we had a really good, oh, sorry, there's a French sentence here. That means he was in a very good attitude. You can see this on the picture down there on the left. But we finally had a recurrence. So we did 2 additional radiotherapy sessions. We gave him another few months of good quality of life. You see, 5 anesthesia, and this cat lived under 21 years old. So that's how you can be very efficient with our orthovoltage machine. Non-surgical thyroid carcinoma. They're often non-surgical. That was UP or Yorkshire. You had on CT thrombosis. You can see here from the sagittal, infiltrative, big lymph node metastasis, hepatic metastasis right there. You had lung metastasis. It's a thyroid carcinoma. So we started with the palliative immunotherapy protocol, no radiation, and usually they respond pretty well. Again, thyrocoxib, metronomic chemo with cyclophosphamide and toceranib or Massivet. Sometimes we use more Massivet first line because you have less side effects, but this one has toceranib. It did well for a year, and then the mass effect appeared. So we gave 3 sessions of radiation therapy, and the dog did well again for another year. After 2 years, we had to stop the meds because of the side effects, and the dog ended up being euthanized 6 months later. So this dog lived with a very bad thyroid carcinoma, non-surgical, just with 5 anesthesia sessions of radiation therapy plus immunotherapy orally for 2.5 years. Melanoma. I told you melanoma, like mast cell tumors, carcinoma, they can melt under orthovoltage. That's a big time melanoma. You do 3 sessions of hyperfractionated, 8 gray, 2 sessions of carboplat on G1 and G21, and it's nearly disappearing. So you know this dog will not be cured. So this is not enough. You can consolidate this protocol with 2 or 3 additional chemo cycle plus immunotherapy behind. But if you have good response, and usually what we told our clients is this protocol with carboplat and hypofractionated, you need to wait at least for 21 to 28 days before you can see if it works or not. And usually when you have such a result, that will mean that you're going to have a long disease-free survival behind. If it's not working right away, usually you may have some late response. Even with this protocol, we've seen it, but I'd say 8 cases out of 10, if you have the response, that's going to be good. 2 cases out of 10, you will not have a good response, and you're not sure that you will be able to do better anyhow. So for the palliative settings, bone neoplasia, analgesia, that's really important. You have to understand that when you use radiation therapy on a palliative setting and on an analgesic settings, that's a main indication in people. For meds in the vertebra, they're using it a lot. So you can have an improvement of the pain within hours after the 8 gray session that you're going to give. Mostly within days, sometimes between weeks. Well, you have a mass effect diminution because you're going to destroy some tumor cells. You're going to have an anti-inflammatory effect. You're going to have an inhibition of the osteoclastic activity. And on the same time, you're going to inhibit, to be able to have an inhibition of the nociceptive mediators that are released by the osteoblast. And you're going to allow a recalcification of the osteolytic tissue. And that will give comfort to your patient. And mainly we're going to use it for osteosarcoma in dogs. And that's the use key we are talking. We've done the CT in 2017. That was the proximal humerus tumor with pulmonary met suspicion. We did a biopsy, it's an osteosarcoma. So we did 4 sessions, 2 sessions of carboplatin at the same time. And we had a recurrence on CT, well, bad recurrence because the dog was still limping, and you can see how much the lung mets did progress from what they were from the first CT, plus vertebral mets. So we tried 2 additional sessions of hypofractionated biphosphonate, tramadol, metformin chemo, but basically worked for 2 months to give comfort to the dog, but he had to be euthanized. But he lived 14 months without amputation. So now, I'm going to do the last part for our protocols, talking to you about intraop. So intraop, we're using empirically, we've been using dose from 8 to 10 gray. I've met personally vets that have been using this technique back in the 80s. I'm thinking about Alice Villalobos, who recently retired, but she did a lot in oncology, you know, for us today. And she used it. And I also, when I was getting training in human medicine for CT scan and for radiation therapy, I met some radiation people there who have used orthovoltage with pretty good results, and they were happy with this machine. So for all these reasons, I wanted to experiment with orthovoltage intraop radiation therapy because I had fairly bad experience with brachytherapy in my clients before. Because for brachytherapy to be efficient, you need your surgeons to be able to put himself the catheter where the iridium granule will go through to irradiate the cat. And it's not that easy to use, very difficult. Most of the time, our cats have pretty big tumor for which this type of protocol is not very good. So plus the intraop radiation therapy. So we decided to use orthovoltage at Eiffelvet. Plus the fact that using brachytherapy, legally speaking, in France is becoming very heavy on an administrative point of view. So, you know, these little black arrow, this is what is left from the tumor after surgery. This is the scar after surgery. That's what you do when you do external beam radiation therapy. So you irradiate all over the places where you think you may have left some tumors. When you do the irradiation of the tumor bed, you're going to give the dose directly where you know that the tumor tissue you may have left in the cat are right there. If you do brachycatheters, and if you position your catheter after the surgery was done, well, you don't really know. You know how cat skin is moving around. How do you know you're going to put your catheter at the right place? And most of the times you don't. And even if you do, using multiple brachycatheters, well, you still are very close right there, and you encounter often recurrence. And there are some data in people. You know, they're using orthovoltage perioperative in abdominal tumors, and it's coming back for soft tissue sarcoma because soft tissue sarcoma in people are really difficult to control, just like it is for us. So there are some data out there in human medicine, and they're using it again. So if this is the tumor, when you're doing carcinologic surgery, you're going to do your CT first, and your aim is to have clean margins 5 millimeters all around your tumors. And if you have a close margins less than 5 millimeters, basically we consider it's dirty margins, incomplete margins, and we're going to proceed with this type of situation in the same way. And again, you can see that when you're doing intraop, you have your CT, you know it's going to be difficult to have your carcinologic surgery despite the CT. So you're better off thinking in advance and planify your intraop surgery to make sure to deal with this little arrow where you know you're going to leave tumor in the cat. So basically, intraop irradiation is about optimizing carcinologic intern surgery with tumor bed irradiation. And we're using it a lot. We're doing a lot of carcinologic surgery. and soft tissue sarcoma, including cat fibrosarcomas, mast cell tumors, melanomas, carcinomas, nasal cavity tumors as well. So if we know from the CT that it's going to be difficult for us to get the margin, the 5mm margins, then we recommend first-line perioperative irradiation. If it's a cat with a very small localized fibrosarcomas, you know that your surgeon will be able to deal with this one. You may not recommend it first line, but even if it's an easy one to go for surgery, but if it's a recurrence, you still will recommend right away the perioperative radiation. Why? Because a recurrence is always much more aggressive than a clinical initial presentation. And then if you know from advance that hyperfractionated protocol will just be impossible to do, and I'm thinking about the cats with either cardiomyopathy or renal insufficiency or both. Well, even if you know you may not need a perioperative radiation to cure the cat surgically, well, you're not going to be able to do additional radiation therapy behind, so you go for it and you do perioperative radiation. And that's a cat with a fibrosarcoma, and basically with our surgeons, you know, from opening the cat in the surgery room, irradiate the cat before closing the cat back in the surgery room and waking up the cat. It's a 2 hours protocol, so it's really quick and efficient. And that's a case where we use it on a nasal cavity tumors. That's Yanto. He has a right calcified tumors, looks like a sarcoma, and it was accessible to transpalatin surgery. That's a really easy way to go in the nasal cavity, providing that the tumor is fairly localized, and it gives comfort to the dog right away. They eat very well the day after the surgery, and so you're opening the soft palate, you're removing the tumor tissue, and you're doing your egg gray within the tumor bed, and you close the dog. This dog lived for 1 year and 5 months just with one procedure of 2 hours. And that's the beauty of these procedures with surgery with perioperative radiation. You need to have your team around. You need to know how to do it, but it's not that difficult. Okay, so the thing is, there are no articles about brachytherapy that really tells you it works or it doesn't work. My experience was so and so, and I wanted to prove and at least to communicate with the vet community about how efficient can be the intraop orthovoltage. So how do we do? So we did a prospective trial at Eiffelvet, and we presented the first data 2 years ago at Houston. You know, you remember that time when we had normal lectures where we can shake hands with our colleagues. And so the standard of care for fibrosarcomas in cats is you do a CT scan pre-op, you do radical surgery. That means 3 centimeters around the margins on the CT. Remember, you're underestimating the volume of the tumor just by palpating the tumor, so you need to do the CT. You're underestimating average by 50% the size of the tumor. So you want to reach 3 centimeters around the margin of the CT, one clean, deep fascial plane underneath, and then you follow by hyperfractionated megavoltage, most of the time with new electrons. So at Eiffelvet, we did the CT scan, we did this radical surgery, but we add the intraop orthovoltage. And if we were not able to get our margins, we will go and propose a hyperfractionated post-op adjuvant irradiation protocol. But we were not doing 3, usually for the hyperfractionated protocol, it's 3 times a week for 4 weeks, Monday, Wednesday, Friday. So basically 3 weeks after surgery, in this case, when your scar is okay, and you gave 3 weeks of hyperfractionated Monday, Wednesday, Friday. That means 9 sessions instead of 12 because you already delivered egg gray within the tumor bed. So that's our protocol. Pre-op scan. You do not have metastasis, and you go for radical surgery with intraop orthovoltage. Some of cases, even though we find metastasis, we know that the lung metastasis will grow very low, so you can still give a chance of disease-free interval significant to certain patients that can be included in a radical surgery with intraoperative. And we end up with, despite our effort and experience, you can see how difficult it is to deal with these soft tissue sarcomas. We end up with 11 close margins, 5 incomplete margins. That means 16 cases out of 28, despite the experience of our surgeons. And there are 2 cases that had clean margins, but the owner considered that hyperfractionated protocol was part of the gold standard and wanted an additional radiation therapy protocol. So for 2 of them, we radiated them, and among the 16 others, only 3 of them the owner accepted for an additional hyperfractionated protocol. So that means we had in our series of 28 cats, 13 cats who should have had additional external beam radiation therapy, but did not have. So 68% of the cats were still alive at the data collection back in October. Most of them are still alive right now. We had 29% wound healing complication, meaning the wound is not healed 5 weeks after surgery. When we compare this number to a normal wound healing complication with radical surgery on soft tissue sarcoma in cats, in the contemporary article, you see we have the same. That means you don't add wound healing complication by giving this A-gray dose in the tumor bed. Median disease-free survival 17.1 months. It seems to be different if you separate the 2 populations in naive fibrosarcomas and recurrent fibrosarcomas. When you look at the survival function, you can see that in our series, basically the cats, they have 60%, 66% chance to be alive without recurrence 24 months after surgery, and 53, nearly half of them, will have no recurrence after 45 months. So it's good. When we try to compare the naive and the recurrent fibrosarcomas, even though when you look at the disease-free survival, 9.5 months versus 19, it was not statistically significant. So there is something there, but we cannot prove it with this series. We try to compare the clean margins cat versus all the other one to see if they were doing much worse than the clean margins. Well, again, there is a tendency with the difference in disease-free survival, 21.4 versus 14.3, but it is not statistically significant. And when we compare our series to the classic article in the literature, you can see that none of them had at the same time radical surgery like in our series, CT scan pre-op, systematic like in our series, somehow radiation therapy, and margins report on a millimeter basis. So that's important because I think that's how we will be able to collect in the future some good data. But anyhow, if I exclude the Italian article, because to me there's a discrepancy in this data because you have an overall survival of 15 months with a disease-free survival of 66. So there are, even they had very good results and their strategy makes sense. I try to compare to the other series, which are more similar to what we're doing, and with no discrepancy in the data. But basically, we're 17 months, and the best series is the Brigazzi series with 22 months, nearly 22 months. But in this series, all the cats are dead at the last data collection. So that means, so basically, with our protocol, we have no significant side effects. We have no additional healing complication compared to radical surgery alone. Our disease-free survival median is comparable to standard of care, if not better. And of course, it's a small cohort, but that's what we deal with veterinary medicine. But with this, first step of data collection from Orthovoltage with soft tissue sarcoma perioperative radiation, I think it's a reasonable alternative. It's a reasonable proof that it's an alternative to standard of care. So the question is, should we increase the dose and go to 12 gray? Well, the last question you may ask me is, why is it working? Because you're doing a surgery like Okay, and just A gray on the tumor bed. And when you compare yourself to 12 to 15 electron linac radiation therapy, it seems to give the result similar. Well, there are a bunch of data out there about this A grade dose that we're using. And again, it was at the beginning an empiric dose, but when you look at the, well, I give you a few articles, but basically what you're doing is you're changing the phenotype with your A grade dose of the tumor microenvironment, and you're switching this microenvironment from a Th2 to a Th1 anti-cancer profile. In fact, you're helping the microenvironment of the tumor to control itself, the tumor. And these A-grade tumors, A-grade dose, somehow it's immunotherapy. So to conclude about orthovoltage, remember that vet oncology, you need to aim at quality of life. You know, it's not like in human patients where they try to give 10 years, 12, 20 years, cure the patient. So they're going to accept a number of side effects. We will not accept these side effects because we will not have the technicity to control our patient and to maintain the quality of life. So ethic in vet oncology is about treating as many patients as possible with affordable treatment and with realistic treatment. You cannot do in dogs and cats what is done in people. Multimodal protocol, for this reason, are usually, in my experience, I've been in oncology for now a long number of years, back to 1991, 1992, and the more I get experience, that means the more I get old, the more I prefer multimodal protocol because it's usually efficient. You're not aggressive with any of the modality. It's well tolerated and gives good result. And in my mind, if you take everything into account, orthovoltage is a very interesting therapeutic modality, and it's answering these goals. And we should, as a veterinary community, try to help to communicate about orthovoltage, because I think even though you cannot do everything with this machine, it's a very good machine and very well adapted to our veterinary life as onco vets. Okay, I hope you now feel like trying orthovoltage, and I thank you, and thanks to Xstrahl for this webinar, and I'll be happy to answer your questions now.
Thank you, Dr. Keravel. That was a great presentation. So we have a few questions coming in here. You had in your beginning of your presentation, you had talked about linac-based radiotherapy. Besides cost, did you consider linac-based systems when you were setting up your program, and what were some of the other considerations?
Well, in Paris, first of all, you know, having big facility and allowing you to have linac within Paris is very difficult anyhow. So even if I wanted to have one as much as I wanted to have an orthovoltage, it would have been difficult. And okay, finance is not the only decision criteria for decision, but still starting with orthovoltage was also a way of starting the practice without being too much dependent on the bank. And it was really part of my reflection. I know that with orthovoltage, I will have a restriction on the indication I can manage with radiation therapy, but that was okay for me.
Okay.
So room in Paris, in big cities, can be an issue, and you don't have that many linac even in human medicine, except in a few hospitals, and usually not within Paris, but rather in the suburbs.
Okay, thank you.
Because of the metro, it's, you know, shielding is very heavy with orthovoltage.
Yes,
Okay.
you covered that. Thank you. Related to the shielding, I guess, and just other requirements, the next question is about what are the service and maintenance requirements for your orthovoltage system?
Well, first of all, every year you need a physician to check on your system to be sure that the doses you are delivering are really controlled. And then we have a distributor in France who is in charge of the maintenance. So usually they come twice a year just to verify everything is fine. So far it's a fairly reliable machine.
Okay, great.
It's not. I'm having dealing. I've dealt with CT for many years, and you always online trying to check for small problems. But it's a reliable machine, fairly straightforward.
Okay, good. We do hear that, so that's always good to hear again.
Yeah,
The next
it's true.
question is about staffing. What is the minimum staff you need to operate the orthovoltage machine?
Well, we have basically the way we work at Eiffelvet is all of our nurses are trained to work with the orthovoltage, and 2 vets are trained to work with orthovoltage. So we always have someone on board, and usually just you need one. Well, you deal with the anesthesia, then you position the animal in the machine, so it's fairly straightforward. And the nurses, we have our protocol, so they know which filter, which applicator for each case. So they usually prepare everything for us to go forward. And again, when I was talking about perioperative irradiation, because as you might have understand, that's a main indication for us. The procedure is straightforward because we thought about this in advance. So the surgery room is closed from the radiation therapy room.
Okay, thank you. Next question, have you treated any exotics, birds, etc. with?
So what we've treated, we are treating quite often thymomas in rabbit. We've also done quite a few total body irradiation for lymphoma in ferrets, and with a pretty good result. I think from the 2 or 3 last ferrets we've done, they lived a year and a half.
Okay, next question is around energy. What energy do you use for cases such as feline nasal lymphoma or palpebral lymphoma? Do you always use 300 kV?
No. We're probably around 270 for these cases, sometimes 230. It really depends, but no, you don't. For cats, usually, I'm not talking about dogs, you don't need to go all the way up to the range of 300 kV.
Okay, next question.
But I don't have I should probably measure and have a median, but I don't have it to be more precise.
Okay, thank you. Next question, which doses of carboplatin as a radiosensitizer do you use? Is it 300 milligrams per?
Well, if we have renal problems, we're going to lower the dose, but if we can, we use the normal dose, which is 300.
All right. Next question. Have you ever seen a patient that presented damage done to the cornea because of a treatment for nasal lymphoma?
We have, as the one I showed, the case of eyelid lymphoma. You have corneal opacification. Sometimes, of course, you may have with time. Sorry, I'm looking for the a lens radiation damage, but it's usually reasonable. To be honest, as time goes on, with my experience of now 7 years with this machine at Eiffelvet, I'm more and more surprised of the low impact of side effects we have. The thing is, statistically, we are doing much more palliative protocols as curative intent protocols. So, of course, when you do palliative, you don't always expect your patient to live for years and to encounter these side effects.
Okay, next question. We are coming up on our time, but I have a couple more questions. Any anti-inflammatory treatments for things like otitis externa? Otitis externa?
We didn't. We propose it sometimes, but since our referral basis is nearly 100% oncology, we usually don't have. We've treated a few cases of chronic inflammatory lesion on the limbs with our hypofractionated protocols. Was pretty good. We treat just like we're treating inflammatory carcinomas, in cats for palliative settings, but not for chronic otitis. I don't have experience for this.
Okay. What kV energy system would you recommend in order to treat and palliate a wide range of conditions?
You mean what? Since Xstrahl can have different. You mean which one to buy?
Yes. Yeah.
I definitely. I have to definitely recommend the 300 because it gives you the acceptable range to do as much indication as possible. You need to go up the range if you want to do palliative for osteosarcomas in dogs, and that's an indication we often have. If you want to give comfort in dogs that have mediastinal involvement with lymphoma, that also helps. So I would be afraid trying to use a lower range equipment might limit yourself, and you are limited by nature having orthovoltage among the indications in veterinary medicine for radiation therapy. So I would recommend 300.
Next question, do you have any experience in association of radio and electrochemotherapy?
The way we do it is we tried electrochemotherapy. Well, you can talk especially for squamous cell carcinoma in cats. So we've used electrochemotherapy. We have the feeling, but we need to produce data. We have the feeling that our protocol with carboplat is sufficient enough, very easy to use, doesn't cause as much pain as when you do electrochemo within the for a cat with squamous cell carcinoma. So usually what we do is, since we expect to have a result on these carcinomas on G21, which is the day for the second carboplat and the third hypofractionated dose, if we don't see a result at G21, if it's getting worse, we're going to go there, and then instead of continuing the protocol, we're going to use electrochemo. I did not. Sometimes we have some response. We've used it also electrochemo for other soft tissue sarcomas. It does something, but it's not doesn't last very long. So far we introducing electrochemo within our palliative protocol with orthovoltage. I do not know, to be honest, if it's the best way to use electrochemo. But my feeling from the small experience as I have with electrochemo is that we're very happy with the palliative protocol with orthovoltage. So it's difficult for us to tell our clients, well, let's go for electrochemo. So we keep it for later when it doesn't work, as we did in the case for I presented a case with a squamous cell trophic carcinoma. We've done electrochemo in a second settings.
Okay, thank you. Two final questions. The use of radiation therapy in veterinary medicine, it's not a wide use. How many colleagues do you see now using radiotherapy, and do you see this as a growing area of interest?
Well, concerning, well, it is. Well, if you go back 20 years ago, there's a huge growth. From what I see in Europe and in France especially, I think the limitation is going to be the price and the expense for the client. And I think now there are some centers that are opening, but we have like less than 5 centers in France, which is not much. I think there are 2 orthovoltage. And I think to answer this question, we need as a community to think about what is the best volume, talking about patients treated. And I think you could imagine having orthovoltage pretty easily spreading, and then in the middle, you have a linac, and then you refer what you can do reasonably with the orthovoltage. And that's the future as I see it, at least in France, because when you think about the price, what we're pricing for, it's less than what is priced for different reasons. Is it right? Is it wrong? I don't know. But we're not pricing. Every veterinary act is not priced as much as it is in England or in the States. So we need to, and that's okay for me. That's my philosophy. We need to try to keep our prices low to afford to treat as many patients as possible. And the architecture with orthovoltage and in the middle a linac where you see in cases you cannot deal with orthovoltage, that's probably the solution to spread radiation therapy in countries like France.
Okay, final question. Are there any resources that you could point people to who wanted to learn more about radiation therapy? Are there any process videos or remote training opportunities?
You're talking about orthovoltage or generally speaking on radiation therapy?
I think generally, the question seems to be more generally speaking, just as an area of development.
Well, I think it's well, because of my age, I went on human medicine and I talked with concerning orthovoltage. I really talked with people who've used it either in the human field or in the veterinary field. So before trying to think about training in radiation therapy, because you can be, of course, there are a bunch of brilliant board certified radiation therapy people in the veterinary, so it's easy to find someone in your country that can help you. But if you want to go into radiation therapy and you're not bothered, and what you have to think is which machine do you want, and then you have to address and talk with people who are using it, and they will, in the veterinary community, we're pretty open, generally speaking, so it's easy for any vet to talk with any radiation therapy vet, and he will give him his opinion. So it's really easy now, much more than what it was years ago.
Sure, yes. Thank you very much. And again, thank you for your excellent presentation today. On behalf of Xstrahl, we want to thank you and all the attendees on the event. As I mentioned at the beginning, we will be distributing a recording of the presentation to everyone who's registered for the event. So look out for that coming to your email. And again, Dr. Keravel, on behalf of Xstrahl, thank you so much for this wonderful educational presentation.
Well, thanks to you. Thanks to you. It was interesting to be able to do this. And if you have, like vet questions to another vet, you can send an email through Xstrahl, and you will redirect the question to me. I will answer it anytime.
Okay. Thank you so much. Yes. So on behalf of all the attendees, if you have any questions for Dr. Keravel, just go ahead and respond to the message with the recording, and we will make sure that he gets in touch with you, that you guys get in touch with each other. Thanks again for your attendance, for your time and attention. And with that, I'll conclude today's session.
Bye-bye.
Thank you so much. Bye-bye.